Good morning, everyone. Today we're going to be, good morning, everyone. Today we're going to be listening to our own Chief Cardiology Resident, Dr. Omar Abdel-Razek. He's giving rounds this morning. We welcome him. The topic of his presentation is Models of Care in the Catheterization Lab, Streamlining the Patient Journey. So please remember to place your questions in the chat box as Omar is giving his presentation. Also remind everyone that next week there is not a grand rounds or cardiology rounds, but rather a quarterly medical and scientific staff meeting, and that will be held via an MS Teams meeting format as opposed to these live events. So welcome, Omar, and we look forward to your presentation this morning.
Okay. I just want to make sure that my mic is unmuted. Okay. All right. Good morning. Thank you, Dr. Stadnik, for inviting me to speak at Grand Rounds. So I'll just get started. My talk is on models of care in the catheterization lab and streamlining the patient journey. So I'm going to talk a little bit about how PCI has evolved from its inception to how we got to same-day discharge and the safety of same-day discharge after PCI. And then I'm going to talk a little bit about early discharge after transcatheter structural interventions, and then prospects for the future. So just a little bit of history. So this is Werner Forsman doing the first coronary angiogram in 1929. He was an internal medicine resident, and he actually used the urinary catheter in the arm through the vein. At that time, it was thought that any catheter or anything in the heart would cause immediate fibrillation. He obviously did not, and he had his friend in radiology take a picture of his first left heart cath. He was actually kicked out of his residency program after this, but his story has a happy ending in that he won a Nobel Prize after this. He actually went on to become a urologist, interestingly enough. This is Dr. Mason Sones in 1958. So this was the first selective angiogram. So this was done while taking an aortogram. A large amount of dye actually flipped the catheter into the right coronary artery, giving the first selective angiogram. This patient actually fibrillated, but was promptly able to be defibrillated. And then in 1977, Dr. Krunzig performed the first angioplasty on a live human. So he was a Swiss radiologist, and he did this for a 38-year-old man suffering from angina. The patient remained conscious throughout the entire procedure, and the procedure was done using balloons and catheters that he actually fashioned himself with his partner. So his first description of PCI was published in 1979. So this is the first 50 patients that underwent PCI. And you can see his results here a whole lot different than what we see now. So he had 18 failed PCIs and 7 requiring emergency bypass. So at the onset of PCI, an OR was always needed to be on standby. So for these procedures. Over the next 25 years, things obviously changed dramatically, and that has to do with the improvement in equipment, operator experience, and sort of the delivery of care of PCI. So this is the first 25 years of experience in PCI at the Mayo Clinic from 1979 to 2003. And this table, or this graph, is just showing the rates of emergency bypass falling from close to 10% in the early 80s to 0.3% in 2003. So that took us from needing an OR on standby to the idea that you may not need surgical on-site backup at all. So this is a meta-analysis over 1 million patients done by Dr. Hibbert and Trevor Samard and Dr. Ramirez. So what they did was they compared patients at surgical sites and non-surgical sites. And what they found is there's no difference in mortality among patients who are at non-surgical sites versus surgical sites, no difference in myocardial infarction, and no difference in the need for emergency bypass. So as a result of this and other data, in 2011, the American College of Cardiology came out with these recommendations suggesting that primary PCI was reasonable in hospitals without on-site surgery, and elective PCI got a 2B indication for hospitals without on-site cardiac surgery. So then that begged the question, what about same-day discharge after elective PCI? So one of the early studies for same-day discharge and elective PCI was done in Quebec. So this is the EASY study. It's a randomized control trial of 1,000 patients, and they were all patients that underwent transradial PCI. They were randomized to same-day discharge versus overnight admission with a GP2B3A infusion, and their primary outcome was urgent revascularization, repeat hospitalization, and complications associated with the procedure. And they found that there was no difference among patients who had same-day discharge versus overnight admission with regards to their primary endpoint, and there's actually no death in the entire study group. Again, has to do an observational studies, or sorry, a randomized study, but has to do with the patient population in that it's a relatively low-risk population. From there, we went. From there, there's this meta-analysis that was published in JACC in 2013, reviewing 5 randomized and 8 observational studies, over 100,000 patients undergoing same-day discharge. So same-day discharge versus non-same-day discharge in patients undergoing uncomplicated PCI. And they were compared on an outcome of total complications, so ischemic complications, vascular complications, and bleeding complications, as well as rehospitalization. And this is the results. So again, no difference between the same-day discharge group and the overnight stay group in patients undergoing elective PCI. So how this looked in practice, this is a study from 2019 reviewing same-day discharge practices in Ontario and the outcomes of patients who underwent same-day discharge. So you can see here from 2008 to 2015, the trend was for an increase in same-day discharge after elective PCI from 17% in 2008 to 45% in 2015. And similar to the studies that I've shown you previously, there's no difference in clinical outcomes either at 30 days or at 1 year. Beyond the safety of same-day discharge, there's also the avoidance of harm related to overnight admission. So as we all know, there are risks associated with unnecessary admission, including hospital-acquired infections, falls, and delirium, overnight admissions related to multiple risk factors for post-hospitalization syndromes. So those are sort of benefits that aren't necessarily measured or represented in the studies that I've just shown. So I've shown clinical safety, or some studies that suggest clinical safety of same-day discharge. So then what are the benefits? Why would we want to discharge people the same day after elective PCI? So this is an observational study of 300 patients who underwent same-day discharge versus overnight stay in low-risk elective PCI. And this is a graph showing their patient satisfaction. So in the same-day discharge group, 79% of patients were satisfied with same-day discharge, as opposed to 49% of those in the next-day discharge group, and very low rates of dissatisfaction in the same-day discharge group. So 9% of patients in the in the same-day discharge group versus 37% in the next-day discharge group. So patients actually preferred same-day discharge as opposed to overnight admission. And then I think the biggest driver is cost. So this is a study from the United States in the Premier Healthcare Database, which is an administrative system that represents about 20% of all acute care hospitals in the U.S. So what they did was they analyzed all PCIs from 2006 to 2015 and compared same-day discharge with overnight admissions, and they reported sort of the difference in costs. This is a busy slide, but just to show that similar to the studies that I presented earlier, there was no difference in clinical outcomes either at 30 days, 90 days, or at 1 year. There was statistically significant differences with regards to total cost. So total costs were lower in the same-day discharge group by about $5,100 in the same-day discharge group, and the biggest driver of cost savings was room and board, so avoidable costs for the hospital systems, room and board, central supply, and ICU stays. And in this database, they estimated if the lowest percentile same-day discharge hospitals sort of improved to the rate of the highest percentile hospitals, it would save $577 million annually across all hospitals. And 45% is sort of close to the number that I've shown you for Ontario in 2015. So if they got closer to where we were 6 years ago, they would save themselves $500 million. And that's an average of $433,000 per hospital that performs 200 elective PCIs annually. And here at the Heart Institute, we probably do closer to 800 elective PCIs per year. And then they also showed a sort of a more conservative increase, showing a $340 million cost savings per year. So big cost savings in the American system. And I show this data because same-day discharge after elective PCI is sort of standard of care in Canada, but it's definitely not in the United States for a multitude of reasons. So to some Canadian data, so this is an analysis of the EASY study that I showed earlier. So that's same-day discharge versus next day or overnight admission. And so they had sort of a complicated economic analysis that I only sort of partially understood, but they estimated the cost of staying in hospital at $65 an hour. Based on average costs for PCI patients admitted at their hospitals, and this was from 2 sites in Quebec, and they showed that the difference in cost was $1,000 or $1,100 per patient, same-day discharge versus overnight admission. And as you might expect, most of this cost was related to overnight stay on the ward. There is a slight increase in cost related to rehospitalization, but as you can see here, outweighed by the savings related to same-day discharge. And as I mentioned, same-day discharge is widely adopted in Canada. And in our last fiscal year, over at least 90% of PCIs are discharged the same day at the Ottawa Heart Institute. So it's sort of more applicable, this information is more applicable to American centers. So as a result, and sort of based on the information that I've just shown, the American College of Cardiology has come out with an expert consensus pathway on same-day discharge after PCI. This was actually published yesterday or on Monday. So topical for Americans more than it is for us. But I just wanted to show that they have this clinical pathway, which I think is really similar to what we already do, to guide same-day discharge after PCI. And they essentially emphasize sort of 3 checkpoints where you can assess a patient for same-day discharge. Pre-PCI, based on clinical and social factors, post-PCI based on procedural factors as well as clinical and social factors, and a discharge based on a follow-up plan that includes cardiac rehab and a follow-up phone call, an appointment with the patient, and discharge prescriptions. So a similar clinical pathway to what we already use, but sort of laid out nicely in a colorful diagram. The Society of Cardiovasculars and for Cardiovascular Angiography and Intervention, SCI, also have a similar statement. And again, it's the same idea. 3 sort of times that you can assess a patient and assess their suitability for same-day discharge, prior to discharge, prior to admission, prior to the procedure, after the procedure, based on the anatomy and clinical and procedural complications, if any, and then at discharge. They were a little bit more prescriptive in terms of the types of patients that they felt were safe to discharge home. Practically, our practice pattern at Ottawa is not as restrictive as their recommendations. So I've shown you information and benefit and the and society's sort of recommendations regarding same-day discharge after PCI. But how about beyond elective PCI? So this is one study for same-day discharge in patients undergoing chronic total occlusion interventions. So this is an observational study of just under 200 patients. And they compared the patients that underwent same-day discharge to non-same-day discharge, and there's no difference in clinical outcomes in patients undergoing CTO revascularization for same-day versus non-same-day discharge. And again, this is similar to what we already do at the Heart Institute. Most uncomplicated CTO interventions will go home the same day, and if there's a complication or if it's sort of a more involved procedures, patients will stay overnight. So just to show that there's feasibility in this intervention. Beyond that, there's elective left main PCI. So this is one study that came out last year from the UK, comparing patients undergoing elective left main PCI, same day versus next day discharge. And again, they show in a larger group, 6,400 patients, 3,500 of which were unprotected PCI, so no alternate flow to the left coronary system. And 40% of patients in their cohort were discharged the same day. There was no difference in mortality between the same day discharge and the overnight stay group in elective left main PCI. We have similar data that we're working on at the Heart Institute. So there's been 461 left main PCI cases since 2008. 267 of them were same-day discharges, and we reviewed them for 30-day death, MI, or hospital readmission. And you can see that there's no difference there's no deaths in the same-day discharge group, there's no MI in the same-day discharge group, and there's very few 30-day rehospitalizations. I'll point out that of the 30-day rehospitalizations, none were within the first 48 hours, suggesting that a overnight hospital admission would not have prevented readmission. And all this is to say that we're good at picking the patients that are safe for same-day discharge, as opposed to saying that the intervention is what's important. It's not that same-day discharge is generalizable to every patient population, but in selected patient populations, it is useful, and we're good at picking patient characteristics of patients that can go home. From the ACS literature, Dr. Chong, Erica McPhee, and Dr. LeMay, with Jeff and Saad, have a protocol for patients to be discharged early after STEMI. And this is just to show that this discharge protocol is very similar to the protocols that I showed you for elective PCI, in that their patients are assessed on admission based on procedural characteristics and post-procedure criteria, and are sort of checked in on pre-discharge and in early follow-up. And they've already shown feasibility for very early discharge in patients after STEMI. So kudos to them for taking it to a higher risk patient population. So that's elective PCI and a little bit of information on acute coronary syndrome. But what about structural interventions? Where are we with regards to structural interventions? So a little bit of history on TAVI. So that's sort of our most common structural intervention. The first in-human TAVI was performed in 2002. Since then, there's been significant reduction in periprocedural complications. And that's associated with a decreasing risk profile of patients based on the results of randomized control trials in intermediate and low risk patient population, although we're not doing them in low risk patients quite yet in Canada, and associated with improvement in technology and operator experience. So this is data from TVT, the transcatheter valvular database, showing the decrease in risk profile of patients undergoing TAVI from 2013 to 2019. So you can see a steady decrease in the complexity of patients that are undergoing TAVI. I apologize for this busy slide, but this is just to show a steady and statistically significant decrease in 30-day death and 1-year death among patients undergoing TAVI from 2013 to 2019, along with a decrease in the requirement for dialysis after TAVI, statistically significant again. Decreased risk of stroke in patients undergoing TAVI in the same time period, and decreased permanent pacemaker rates after TAVI. And going along with the theme of this talk, earlier discharge, so the median length of stay decreased over the same time frame from 7 days in 2013 to closer to 2 days in 2019. And there is some data suggesting that early discharge is safe in patients undergoing transcatheter aortic valve replacement. So this is a meta-analysis of 8 studies, 1,700 patients, comparing early discharge, so less than 3 days, to standard discharge with regard to 30-day mortality, 30-day readmission, and the need for permanent pacemaker. So you can see here there's no difference in 30-day mortality and no difference in 30-day readmission in patients undergoing early discharge in this meta-analysis. In a more sort of a more contemporary observational study from 5 sites in Italy and 2 sites in the Netherlands, 3 sites in the UK, they classified patients as low or high risk for early discharge, 503 patients in this study, and they compared them on a composite endpoint that included mortality, vascular complications, pacemakers, thrombotic events, and bleeding at 30 days. And they show that there's no difference in their primary, no difference. The same day discharge, or the early discharge in low risk patients, was actually associated with a lower risk of complications. So again, and I haven't shown how they chose their low and high risk. It's a grocery list of patient factors, mainly describing the frailty of patients. But in patients who are deemed to be low risk, early discharge was better did better than patients who were high risk and required longer hospital admission. In terms of which clinical factors affect the decision to make to discharge a patient early after TAVI, this is an observational study of 360 patients this is from Atlanta in Emory, 360 patients undergoing balloon expandable TAVR. And the predictors, and so this study was meant to look at the predictors of next day discharge, as well as a composite of mortality and readmission at 1 year. So when they looked at which factors sort of influenced operators to discharge patients earlier, they found 4 associated with statistical significance, being age, male sex, a lower serum creatinine, and a lower SES prom score, a lower surgical risk. And there was no difference in outcomes at 30 days, but there was decreased mortality and readmission in the next day discharge group, again suggesting that patients who are carefully selected for next day discharge do no worse or better than patients who are higher risk. In terms of a clinical pathway for patients undergoing TAVI, the Vancouver group came up with this multidisciplinary, multimodality, minimalist next day discharge algorithm or clinical pathway. So this is patients undergoing transfemoral TAVI in Canada. So they included any patient who was deemed to be high risk by the surgical team or the heart team, sorry. And they excluded, so it's a pretty broad net they cast in terms of patients that they included in this study. They excluded patients who were essentially, as I showed you before, frail. So life expectancy less than 3 years, issues with vascular access, issues with clinical stability and mobility, and issues with cognitive impairment were not eligible for the study. But essentially everybody else was. And this is sort of the clinical pathway that they came up with. So patients go to a hybrid OR with sort of a minimalist anesthesia approach, and they're assessed with a transthoracic echocardiogram peri or post procedure. They're followed closely clinically for the first few hours, so Q15 clinical checks and Q30-minute clinical checks along with blood work on post to update 1. Early nurse-led mobilization after 4 hours of bed rest, and they emphasize the communication from the multidisciplinary team as being a important cog in making sure that this clinical pathway is effective. The next day, transthoracic echocardiograms are assessed, and ECGs, as electrical complications, are a major concern in patients undergoing TAVI. If there's no clinical concern for conduction delay and there's no vascular access complications, patients are felt to be safe to be discharged home. I mentioned conduction delay as it's a pretty important factor in deciding on whether or not to discharge home a patient after TAVI, and I won't delve into it too much, but there is a consensus document on who to send home and who requires a longer monitoring period and who requires pacemaker, which is very similar to what we do in Ottawa with some minor differences. In terms of the patients in this study, I just show the baseline characteristics quickly. I know this is a busy slide, but the baseline characteristics are relatively similar to the patient population that have TAVI here at the Heart Institute. And in terms of how patients did who were enrolled in this study, the risk of 30-day mortality or stroke was relatively low, 2.9% in the entire cohort, in a cohort that achieved 80% next day discharge. So they were able to discharge a lot of their patients early with low complication rates. And their complication rate is similar to what's seen in the literature. So there are 1.5 mortality rate, 1.5 30-day stroke rate is similar to what's seen in registry and randomized control data. With regards to our own numbers, there was 196 transfemoral TAVIs performed in Ottawa, 128 of them were elective outpatients, and 115 of those 128 were actually discharged within 48 hours. So we're already sort of following this clinical pathway with success. So I've shown you that it's feasible, and I've shown you a potential clinical pathway for discharging patients early in TAVI. What about cost effectiveness? So this is an economic analysis of the Partner A cohort, and this is just to show that in this study, this was the first sort of one of the first TAVI studies. Hospital admissions were long, 10 days for the transfemoral TAVI group, so much longer than the next day discharge that I've suggested. And this is just to show that total upfront admission costs were similar in patients undergoing TAVI compared to patients undergoing surgical AVR, with most of the upfront costs being related to the price of the valve, which will eventually decrease as and has already decreased as sort of more competitors are on the market, and the price of the valve actually goes down. And this is just showing the resource use and costs of the transfemoral cohort at a year, and again, no significant difference in the cost at 1 year between TAVI and surgical AVR at a year. This is also from the partner trial, just showing that, as I mentioned, a lot of the cost is related to the price of the device, which is a moving target, but not one that we can actually change or at a hospital level make a difference on. But a big driver of cost is room, overhead, and personnel. So this is an economic analysis for all so a retrospective observational cohort study of all fee-for-service Medicare beneficiaries who underwent elective TAVI in 2016. And they did a logistic regression to sort of determine the differences in next day discharge versus prolonged stay. And what they're showing here that in elective cases that undergo next day discharge, the savings are $7,500 per patient, $5,200 in their analysis that included hospital dummies. They also did a sensitivity analysis for longer admissions, so next day discharge versus 2 days versus 3 days and versus 4 days. And as you might imagine, sort of the cost savings increase when you compare shorter stay to longer stay. Again, this is American data. There's no similar Canadian data yet. Yeah, nothing yet. This is just quickly to show that same-day discharge for TAVI has been done and has been described. I'm not sure if we're there yet, but it has been described. So this is a very small cohort in Atlanta from Emory of 29 patients that were discharged the same day. And this was sort of born out of a need to conserve beds for COVID-19. So this was published last year. And their primary endpoints here were mortality, delayed pacemaker insertion, stroke, and CV admission. So they sort of came up with this clinical pathway for who would be safe to be discharged the same day. So they excluded any patient who was over 90, high STS-PROM scores, low LV function, as well as clinical markers, other clinical markers. They also considered procedural variables, so any patient who had a vascular complication, required intubation, or required a pacemaker was not eligible for same-day discharge, and anybody who developed a post-procedure complication or had surgical or had social barriers to discharge. So again, just a potential clinical pathway for patients undergoing TAVI to have same-day discharge. from one site in the United States. And so what they did sort of practically is patients had their TAVI, they had an ECG at 4 hours. They were assessed by a nurse for exclusions to same-day discharge, and they were reassessed by their structural heart provider for same-day discharge, and then they were followed up clinically with a telehealth visit the next day, an ECG and an echo at 30 days, and lab work at 48 hours to assess for potential complications. What they showed was that there wasn't any difference in 30-day outcomes in this highly selected group. So just to say, there is potential for feasibility for same-day discharge in patients undergoing TAVI. So what about other structural interventions? So mitral clip being one of the newer structural interventions. This is one observational study from a Turkish group suggesting that same-day discharge is feasible. Small numbers, so only 82 patients post-transcatheter mitral valve repair. All these patients underwent moderate conscious sedation, which is different than what we do here, and they only included patients in the study that didn't have procedural complications and were ambulatory with no access site bleeds, and all patients were followed up early in the post-discharge phase in cardiology clinic for removal of sutures and repeat echocardiography. So just to look at their baseline characteristics, so a pretty representative group, and they included both primary and secondary MR as part of their cohort. In terms of clinical outcomes, there was hardly any clinical outcomes. Again, not suggesting that same-day discharge is safe for everybody, but in a highly selected patient population or in patients who are safe to be discharged home, felt to be safe to be discharged home by their treating clinician, they are unlikely to have complications. And so these complications were judged at 30 days. And again, similar to TAVI, a lot of the upfront cost is related to the device, not a cost that we can make a change in, but room and board is obviously a big part of the cost, and something that we can actually, if same-day discharge or early discharge is feasible for patients undergoing mitral clip, it's somewhere that we can make economic improvements. And this is a cost analysis of the COAPT trial that I'm showing here. This is a study of nationwide readmission rates in the United States after mitral clip at 30 days. So they just sort of analyzed all patients that went home early and compared their outcomes. This is just to show that in patients who are felt by their clinician to be safe to be discharged early within 48 hours, the readmission rate is lower than patients that are felt to require a longer admission. Just to show that the majority of readmissions in patients who undergo mitral clip and have next day discharge or early discharge, the majority of readmissions are related to heart failure as opposed to post-procedural complications, indicating a possible different mechanism to avoid readmission as opposed to longer or overnight stays. This is one other study of a German group published in 2017 of 271 patients undergoing mitral clip, comparing deep sedation to general anesthesia as a potential for decreased hospital admission or decreased in-hospital stay. there was no difference in clinical outcomes between general anesthesia and deep sedation, no statistical significant difference anyways, but there was a statistically significant difference in length of ICU stay. So patients who underwent moderate conscious sedation actually did better or had shorter stays in hospital, in ICU. Finally, there's the Watchman left atrial appendage occlusion and same-day discharge. So there is one study. This is from Brigham and Women's Hospital in Boston. 211 patients undergoing left atrial appendage occlusion, assessed for a primary outcome of stroke, systemic embolism, major bleeding, and vascular complications, and death. And patients were their sort of clinical pathway was patients were extubated after the procedure, they were ambulated after 2 hours, and they were assessed for eligibility by their treating physician, and if they were felt safe for same-day discharge, they went home. If not, if they had a serious complication or a procedure-related complication, they were kept in hospital. And there was no difference in clinical outcomes peri-procedurally or at 45 days between the two groups. So to conclude, it took from 1979 to 2015 to achieve 50% same-day discharge in Canada. So 35 years to get from inception of the procedure to same-day discharge in a significant portion of patients. TAVI, it's taken us a much shorter period of time, 18 years from the first TAVI until 90% of patients getting early discharge, so next day discharge, not same-day discharge. The horizon is, is interesting, and it'll be interesting to see how quickly newer procedures and transcatheter interventions are obviously blowing up with more and more options available. It'll be interesting to see how quickly these procedures move to an early discharge and a protocolized algorithm for early discharge. And a lot of this is based on significant reduction in complication and associated with improved technology and operator experience. But we need protocolized discharge algorithms that address clinical and non-clinical barriers, that assess patients in the pre-procedural, procedural, and post-procedural phase to identify patients that are suitable for discharge. And I think what will be important is looking at our own data and sort of re-looking at our data and seeing which patients are safe for early discharge and which patients suffer late complications and which risk factors are associated with late complications to help make decisions on which patients are safest for same-day discharge. And in the long run, same-day discharge will lead to improved resource utilization and patient satisfaction. And that's all I have. Thank you for listening.
Thank you, Omar. That was great. Got a little bit of feedback. I'm not sure if Dr. Labanez, who is also moderating today, has any comments to share.
Sorry, Ali, I couldn't hear you. There's so much feedback. What? I heard my name, but do
you have any comments?
Oh, no. Well, yes, I think, Omar, you did an amazing job to kind of describe the changes that we've seen in interventional procedures and how this has kind of moved forward in a logical state. The summary was excellent. And, it really lays the groundwork for how we think moving forward with the new technologies. I think this is an excellent talk for, all of our colleagues outside of, the structural world to kind of see where we're at with things. Because, TAVI has changed so dramatically, for example, from the early days when we did our first procedure in 2007, which was a big deal. Now it's basically we tell people it's a day procedure, and we're just keeping them overnight for observation. So we're excited about this, just to help also get people informed that we're opening a new structural unit in the reference center April 1st. We just had one of our last meetings yesterday, and so TAVI patients will be going through this structural unit with the MRP being structuralist. So hopefully very few patients going to the wards to allow them for rapid discharge and good communication with their families. So things are changing. We haven't done that yet for some of the other procedures that still require general anesthesia. Having said that, general anesthesia is probably going to be still required for some procedures. Like, many people don't like to have a transesophageal echo down their throat for 45 minutes to an hour. So I can't, whether or not we get around that with ICE, that's sort of something that's we're starting to explore for some procedures. But yeah, it's an exciting time. I think it really shows a good collaboration between all aspects of healthcare with anesthesia and the importance of imaging and new developments with catheter-based interventions. But great job, Omar. Really enjoyed it, and you highlighted a lot of the important issues with the process of these patients.
Thanks, and sorry about the feedback. I didn't realize it was. I hope it's, yeah. Sorry about that. I hope it was. You guys could hear what I said.
Oh no, you were clear, Omar. It was just Ellie's question that had all the feedback.
Yeah.
It's just me.
Okay, I was getting worried.
I'm not sure if there's feedback now. I hope not. One question from the audience, Omar, can you just comment on why you think the practices are so different between the United States and us? Do you think this is a product of their HMOs, various remuneration systems, in all of your reading? Why do you think that is?
Yes, for sure. So I think a big part of it has to do with how hospitals in the United States are remunerated. So oftentimes hospitals are incentivized for keeping patients overnight, and that certainly shapes practice patterns in the United States differently than the way we are in Canada. So I showed a TAVI study where they did same-day discharge, and they only got to 29 patients, and that was. They explicitly say in the paper that was related to the idea that they were not getting paid for patients that they were sending home the same day. So I think the economic model and the reimbursement model in the United States is a big driver. I think the other part of that is they have a more litigious medical system than we do, and it seems like in all literature that I've read, American centers err on the side of caution, probably for fear of lawsuits.
Great. Well, that was an excellent presentation. Thank you so much for updating us on the progress that's been made. That brings us to the end of rounds this morning. Again, next week is the quarterly staff meeting, so you'll get a different type of Microsoft Teams invite for that. And have a good day, everyone.
If I can just say one last thing, Omar, as well, congratulations on a great presentation, and to echo Dr. Lavina's comments, a lot of great progress being made, and your talk kind of highlights the way things are moving forward, and we're excited about the new structural unit and the ability to really help these patients with their recovery and for timely discharge and so on. So thanks again, Omar. Great work.
Thank you. Have a great day.